Today we will have discussion on drugs and kidney injury. I'll be covering most of the drugs except chemotherapeutic agents. The history of drug nephrotoxicity goes to Hippocrates, who observed variations in urine production and kidney function based on the intake of exogenous compounds like food and liquids. And in 1933, Bell ME published a case report of nephrotoxicity by cysteine. And today, this area of research is extensive and crucial for monitoring the safety and efficacy of drugs, both for the established and the novel ones. Why kidney is more sensitive to nephrotoxins? Because of its complex anatomy and physiology, that is high blood flow and presence of various types of xenobiotic transporters, extremely active enzymes which perform intrarenal biotransformation of substances, and high concentration of filtered compounds in the tubular structure and inability of the damaged nephrons to regenerate. The nephrotoxicity is common in our outpatient and inpatient nephrology practice, and this accounts for 25% of the serious drug side effects. It can be functional or structural. And this can be dose dependent based on the dose and the duration and the concomitant nephrotoxins and underlying CKD. And other one is idiosyncratic reaction. This is complex, unpredictable, and highly variable between the individuals. And if it is rechallenged with either the same drug or the other drug from the group, it can result in the same reaction. And so complete avoidance of the that particular drug is needed. Types of drug nephrotoxicity, it can be acute tubular injury, acute interstitial nephritis, crystal-associated nephrotoxicity, glomerular disease resulting in proteinuria to nephrotic syndrome, and proximal distal tubular dysfunction causing electrolyte and fluid imbalance, and ultimately chronic kidney disease. Mechanism is acute tubular injury by toxic damage to various cellular functions, and AN by T cell mediated immune response resulting in induction of inflammation within the tubulointerstitium, and crystal nephrotoxicity by insolubility of the drugs in urine resulting in precipitation as crystals, especially in the tubular lumens, rhabdomyolysis, TMA, and changes in glomerular hemodynamics. So moving to the most common manifestation, acute tubular injury. Around 20 to 30% of a drug is actively transported to PCT cells through the basolateral membrane, through organic anion transporters. And inside the cell, it decreases the mitochondrial DNA content by inhibiting the mitochondrial DNA polymerase and resulting in cell apoptosis and necrosis, leading to AK. Then the drug should be secreted to the tubular lumen by the apical membrane transporters, that the MRP2 and MRP4. The drugs which interfering these transporters can result in prolonged action of the toxic drug in the proximal tubules, can causing necrosis and necrosis of the cells. The risk factors for acute tubular injury can be modifiable or non-modifiable. Modifiable ones are volume depletion and hypotension, exposure to concomitant nephrotoxins, and the dose and the higher dose and the duration of therapy, and if the drug is not modified for underlying GFR. And non-modifiable is advanced age of the patient with a concomitant CKD and comorbid conditions, high-risk settings, shock states, transplant patients, and the patient who is genetically vulnerable are the risk factors for acute tubular injury. Prevention and treatment, there is no specific therapy. Identify the offending drug and stop it at the earliest. And the other conservative measures only we can do. Improving the perfusion by IV fluids and avoiding concomitant nephrotoxins and utilizing sensitive biomarkers if it is available. These are the drugs in acute tubular injury, main drugs in acute tubular injury. Among the antibiotics, aminoglycosides. The preventive measures for aminoglycoside nephrotoxicity, we can use once daily dosing or use the least nephrotoxic one, that is use tobramycin over gentamicin. Vancomycin, make use of therapeutic drug monitoring, keep the trough level less than 15 nanogram per ml, and avoid combination with the piperacillin tazobactam and other general measures. Colistin, polymyxin, this also result in ATN. The usual preventive measures we can use. Antifungals, amphotericin B, prefer for lipid or liposomal forms. Antivirals, analgesics, and calcineurin inhibitors and bisphosphonates. These are the drug classes, medication class causing acute tubular injury. The second manifestation, acute interstitial nephritis. This is an immune-mediated injury with infiltration of immune cells in the tubulointerstitium. And this accounts for 15% of the biopsy performed for acute kidney injury. And most of the time, more than 70% is by drugs. Acute interstitial nephritis is by drugs. These are the medication classes associated with acute interstitial nephritis. In this also, most commonly, antibiotics, beta-lactams, sulfa-containing drugs, rifampin, and fluoroquinolones. Anti-acidity drugs, mainly proton pump inhibitors, analgesics, immunotherapies, anti-angiogenesis drugs, diuretics, antivirals, anticonvulsants. The difference between acute interstitial nephritis by antibiotics and NSAIDs, antibiotics, this accounts for nearly half of acute interstitial nephritis, and the peculiarity of antibiotic-associated AIN is it is of rapid onset with typical allergic features. And that will help in early diagnosis and treatment of acute interstitial nephritis. But in case of NSAIDs, it usually manifests after weeks or months after the drug initiation and will not be having typical allergic features. And that will result in diagnosis will be a challenging and increasing the need for kidney biopsy. Pathogenesis of acute interstitial nephritis. This is a T-cell driven process. The drugs will bind to the tubular base membrane as and will act as a hapten or prohapten, or it will be behave like a planted antigen. And that will this antigen presenting cell will recognize this, and that will move to nearest lymph nodes and result in adaptive immune response by CD4 T cells, resulting in various cytokine productions, and that will attract number of cells, which ultimately resulting in acute interstitial nephritis. And there are reports showing certain HLA variants that is associated with the severe acute interstitial nephritis in acute interstitial nephritis. Diagnosis of acute interstitial nephritis, typically if the allergic manifestations, the triad is there, the diagnosis will become easy, but it is seen very rarely, less than 10%, and especially with the antibiotic-associated acute interstitial nephritis. Pyuria can be there, leukocyte cast is rare, urine eosinophil is rare, and the use of novel urine cytokine markers, especially interleukin-9 and TNF-alpha. This is present. It is independently predictive of acute interstitial nephritis. And there are some reports which is showing it may even replace the need for biopsy. And kidney biopsy will show interstitial inflammatory infiltrate and tubulitis. Treatment is identify the drug, stop the drug, and use of corticosteroids, which will be beneficial in patients with biopsy showing greater interstitial infiltrate and higher EGFR before biopsy and higher urine interleukin-9 levels. Dosing regimen is not standardized, and earlier the treatment, better the outcome. There is no difference between shorter course, longer course, and higher IV dose or oral dose. Better to start the treatment at the earliest, usually oral corticosteroids for approximately 4 to 6 weeks. If at all recovery, it will happen within this time. And then if no recovery, rapid taper if no response is seen. Because interstitial fibrosis and inflammation usually noted within 1 month. And 50% of CKD from ongoing tubulointerstitial inflammation and fibrosis. And there is limited data regarding other immunosuppressive agents like azathioprine and mycophenolate other than corticosteroids. The third common manifestation is crystalline nephropathies. This is less common than ATN and AAN. It is characterized by urine showing crystal containing cast, and histologically it can show intratubular crystals. This intratubular crystal deposition occurs because of the increased drug supersaturation in the urine, especially with the volume depletion, dehydration, that will lower the urine flow rate, and high drug concentration, that will increase the urinary drug concentration, and urine pH influencing the supersaturation and underlying CKD. Pathogenesis, kidney is the ideal site for crystal deposition. Why? Because when the drug traverses the tubules, high drug concentration results in supersaturation, and the nature of the crystals also facilitate, and presence of injured cell membrane will provide a nidus for crystal nucleation adhesion, upon which further crystal growth occurs. And then this crystals induces inflammation and necroinflammation, and this crystals also resulting in cell necrosis by destabilizing the lysosomes, releasing its contents, causing cell necrosis via autophagy and necroptosis. So these are some commonly seen drugs causing crystalline nephrotoxicity. Among this, methotrexate. Methotrexate, it is Along with the common preventive measures, we can alkalinize the urine and use of folinic acid and glucarpidase. It is a bacterial recombinant enzyme. It is usually given with high dose methotrexate to prevent nephrotoxicity because it cleaves the methotrexate into inactive metabolites and helps in alternative route for elimination. In rare situation, high flux HT can be used. Other drugs, sulfadiazine, sulfamethoxazole, indinavir, etesonavir, darunavir, cyclovir. To prevent cyclovir crystalline nephrotoxicity, avoid rapid IV bolus and adjust the dose for kidney function and keep good hydration. Moxilin, foscarnet, and sodium phosphate purgates. These are the drugs which can result in crystalline nephrotoxicity. There are some drugs which can cause nephrotic syndrome, like NSAIDs and selective COX-2 inhibitors, antimicrobials, ampicillin, rifampicin, cephalosporins, lithium, dipenicillamine, pamidronate, sulfasalazine, gamma interferon, and mercury exposure in skin lightening creams, immune checkpoint inhibitors. All these can result in nephrotic syndrome. About pseudo-AK, some drugs, without causing drug injury, it can result in false elevation of creatinine. That is by cimetidine, trimethoprim, dronidaron, cobicistat, dolutegravir, tyrosine kinase inhibitors, pyrimethamine. That will decrease the creatinine secretion through the proximal tubular cells into the urine and falsely elevate the creatinine value. Dexamethasone can also result because some of the formulation will contain creatinine as an excipient. And cefoxitin, this is recognized as a creatinine chromagen by the alkaline picrate method for method of creatinine analysis. Flucytosine, that will interfere with the enzymatic assay of serum creatinine determination. And corticosteroids, by its catabolic state, releasing the creatine from the muscles and will be converting to creatinine in the circulation. And fenofibrate, increasing the metabolic production of creatine. So these are examples of pseudo-AK, drugs causing pseudo-AK, and hemodynamically mediated AK by is angiotensin converting enzyme inhibitors and angiotensin receptor blockers, NSAIDs, SGLT2 inhibitors, and calcineurin inhibitors by interfering with the afferent and different arteriolar vasoconstriction. About some of the commonly used drugs resulting in acute kidney injury, NSAIDs by blocking cyclooxygenase enzyme. This cyclooxygenase enzyme is needed in producing prostaglandins, which regulates the vascular tone and salt and water homeostasis. In this table, we can see that this COX-1 and COX-2 both are expressed in the kidneys. COX-1 is a constitutive expression and COX-2 is inducible with pain and inflammation. So the non-selective one will block both the enzymes, and it can result in alteration in intraglomerular hemodynamics, AAN, ATN, MCD, glomerulopathies, and papillary necrosis, resulting in fluid retention, reduced GFR, hyperkalemia, nephritic or nephrotic syndrome, hypertension, and AK with excessive high dose and longer duration usage, especially in patients with underlying renal dysfunction, elderly patients, and neonates, can result in these toxic manifestations. And studies have demonstrated no difference in nephrotoxicity between selective and non-selective COX inhibitors. So use the lowest effective dose for the shortest duration and make use of, if available, early detection by biomarkers like taurine, tryptophan, and tyrosine, that the urinary metabolites will detect NSAID-induced nephrotoxicity earlier. Among antibiotics, these are the commonly used antibiotics resulting in nephrotoxicity. Aminoglycosides by tubular toxicity, it can ATN mainly, but can also result in Fanconi-like syndrome and electrolyte wasting tubulopathies. Beta-lactams, both ATN, AAN, and glomerulonephritis, it can cause. Trimethoprim sulfamethoxazole, it can cause false elevation of creatinine, and ENaC inhibition will result in hyperkalemia. Vancomycin, tubular cytotoxicity resulting in ATN, AAN. Daptomycin by rhabdomyolysis, myoglobin-induced tubulopathies. Polymyxin, usually ATN. Aminoglycosides, this causes dose-dependent nephrotoxicity around 5 to 25%. The cationic amino group helps in binding with the anionic phospholipids on the PCT membrane. So higher the cationic amino groups, that will be more toxic. And out of this, neomycin has the greatest affinity and more toxicity. Usually, it results in a non-oliguric AK by 5 to 7 days with electrolyte abnormality, with or without polyuria, with Fanconi-like syndrome. The peculiarity is around 5 to 10% of the parental dose will be retained in the S1 and S2 segment of PCT, where it can achieve concentration greatly exceeding the concurrent serum concentration. So AK can even develop even if your serum drug level is closely monitored. And also kidney failure may become clinically apparent as late as several days after the drug has been discontinued. Risk factors, along with the common risk factors, the type of aminoglycoside and the frequency of dosing for aminoglycoside nephrotoxicity. So how to minimize nephrotoxicity? By selecting the least toxic aminoglycoside, that is gentamicin is the most nephrotoxic, coming in the decreasing order: tobramycin, amikacin, litilmycin, and streptomycin. And also, when you are starting aminoglycosides, if there is an underlying hypokalemia, hypomagnesemia, that should be corrected, and availability of pharmacokinetic monitoring and once daily dosing regime is preferred. TDM for aminoglycosides. The updated 2023 IDSA contains supplement with therapeutic drug monitoring recommendation for aminoglycosides. This aminoglycoside has got a optimal action when the maximum concentration is more than 10 times the minimum inhibitory concentration of the organism. So they keep a target 24-hour area under the curve by minimum inhibitory concentration ratio of 80 to 100. So how to prevent and manage? Proper monitoring of kidney function and adjust the dosage and therapeutic drug monitoring, and early detection by biomarkers like KIM1, NGAL, microRNAs. And there are some reports, but preclinical studies of the role of antioxidants in reducing aminoglycoside-induced nephrotoxicities. But further research is required. And the role for statins, that will inhibit the mevalonate pathway that prevents the aminoglycoside accumulation in the cells. Vancomycin. Vancomycin also results in ATN, 0 to 20% chance, especially if administered along with piperacillin tazobactam. Usually noted 4 to 8 days of therapy. Therapeutic range trough level should be kept. There is availability of vancomycin drug level monitoring. Trough level should be kept between 15 to 20 microgram per ml. A 5 microgram per ml increase is associated with high risk for AK. So the prevention is use of continuous infusion dosing and AUC by MIC based dosing strategies. But because of the cumbersome nature, AUC trough monitoring is preferred over AUC. Polymyxins, this is noticed, ATN is noticed by 4 to 5 days, and the incidence is 8 to 60%. This causes the damage to PCT membrane by its detergent activity, resulting in iron and water influx into the cell and cell swelling and cell death. Convincing data is not their role for antioxidants to prevent polymyxin nephrotoxicity. Colistin versus polymyxin B. There are many studies. They have demonstrated that due to the difference in pharmacokinetic profile, colistin associated with more nephrotoxicity than polymyxin B, because colistin has a flat concentration versus time profile, while polymyxin B has a larger peak to trough variation. And also for polymyxin B, renal clearance is the minor elimination pathway. Antivirals, antiretrovirals, reverse transcriptase inhibitor, tenofovir is associated with the Fanconi-like syndrome. And ritonavir, indinavir, protease inhibitors, they can result in nephrolithiasis. But when we combine tenofovir and ritonavir, the tenofovir clearance is disrupted by this. Ritonavir will inhibit the transporters, and that will lead to accumulation of the tenofovir inside the cell, and marked toxicity of it will be there. So close monitoring of kidney function is required when we are using tenofovir and ritonavir combination. Tenofovir alafenamide is less nephrotoxic due to its conversion to active drug, which occurs in lymphocytes. That will result in much less plasma level. Amphotericin B, this also causes dose-dependent ATN, and it can result. This is usually reversible, but higher cumulative dose, if it goes more than 4 grams, it is associated with a permanent kidney damage. Liposomal forms that will improve the pharmacokinetics of the drug to reduce the toxicity, but still has nephrotoxic potential. Proton pump inhibitors, especially the omeprazole and lansoprazole, and rarely by H2 blockers, cimetidine. It can cause acute interstitial nephritis by idiosyncratic reactions. And usually the case reports have shown by an average period of 4 weeks after therapy, AK develops. But long-term use of proton pump inhibitors, there are many reports which is showing around 40% risk for CKD and kidney failure, even without an intervening AK manifestation. Immune checkpoint inhibitors, this also result in acute interstitial nephritis, especially when it is combined with the proton pump inhibitors, and its toxicity usually manifested after 16 weeks of drug initiation. And the management is by drug discontinuation and corticosteroids. Biomarkers for early detection of drug-induced nephrotoxicity, depending upon the nephron segment involvement by the drug, the biomarkers, various biomarkers are there, but the availability of each one, I'm not sure. So the impact of drug-induced kidney injury, patient impact, it can result in acute kidney injury, chronic kidney disease, end-stage renal disease causing over 1.5 million adverse events annually. Healthcare impact, it can increase the healthcare cost, hospitalization, and dialysis treatment. Pharmaceutical industry impact, drug failures due to nephrotoxicity are the major concern for the pharmaceutical industry. So around 82% of the drug project closure is by safety toxicity related failures. And out of this, renal injury accounts for 8 to 9% of preclinical and clinical failures respectively. Thank you.